Okay, acute megacolon, aka acute colonic pseudo-obstruction, aka Ogilvie syndrome, occurs to very ill patients who have just gone under a major surgical procedure. The pathophysiology is when you have acute dilation of the colon in the absence of any obstruction whatsoever, and you characteristically see this in very severely ill patients or postoperative patients. The etiology of Ogilvie is idiopathic. However, etiological factors can cause impairment or destruction of the autonomic nervous system, and you have this non-homeostasis between the sympathetic and parasympathetic control of the intestinal motility. You have accumulation of feces, air, and secretions within the intestine, and eventually you get this colonic dilation, which is why it's called acute colonic pseudo-obstruction. You want to look for electrolyte derangements like low potassium, low magnesium, and low calcium. The patients can also have been using opioids or anticholinergics. And lastly, don't forget to rule out neurological disorders like stroke. The patient will present with abdominal distension, they'll have some pain and obstipation, and even sometimes vomiting. When you do a physical exam, you'll have tympanic percussion and decreased bowel sounds. Always remember, if the patient has guarding, rigidity, or rebound tenderness, you have to suspect perforation. On imaging, you want to look for colonic dilation or normal haustra with a non-dilated small bowel on x-ray, and on CT scan, you want to look for colonic dilation without any true anatomic obstructions. We manage these patients with keeping them NPO with a nasogastric or rectal tube decompression, and neostigmine can be given intravenously if the patient does not improve after 2 days or if the cecal diameter of imaging shows that it's longer than 12 centimeters. When it's longer than 12 centimeters, it's a very strong predictor of having a future perforation. Don't pick hypoperfusion of the colon if the patient is presenting with some sort of abdominal pain, because if the patient truly has ischemic colitis, they will also present with hematochezia, and colonic dilation actually isn't typical. Also, don't get tricked into picking toxic megacolon unless the patient is septic, showing fever, leukocytosis, and if they had recent travel outside of the United States. Ulcerative colitis can also cause abdominal pain, but again, this causes hematochezia and also weight loss in the patient.